Good afternoon. I'm Patty Johnson, coordinator of the Southeastern Council of Foundations EngAGEment Initiative. This afternoon, we're delighted to present our program, Vision Rehabilitation in Older Adults, sponsored by the Eyesight Foundation of Alabama and presented by Tori DeKaiser of the Eyesight Foundation and Dr. Don DeCarlo, director of the University of Alabama at Birmingham's Center for Low Vision Rehabilitation. Tori, I'm going to put this program into your hands and those of Dr. DeCarlo.
Thank you, Patty, and I welcome everybody and appreciate your interest in this topic, which is a very special topic for the Eyesight Foundation. Just to give you a little background, we were created as a health legacy foundation about 15 years ago with assets of about $50 million that resulted from the sale of a specialty eye hospital here in Birmingham, Alabama. And our mission since inception has been to serve as a catalyst for improving eyesight through education, research, and access to care. In the early years of our foundation, we commissioned an Alabama Eye Health Needs Assessment to have some intentional data that would help guide our grant making. And this study, which was a statewide report, was commissioned in 2000, and among many needs, unmet needs in the eye care realm, it was revealed that there is an absence of rehabilitation training and equipment aids for individuals with severe vision problems. And that's across the board. It's not based on people who are financially challenged, but it's just people with severe low vision. What we did with that information is we partnered with the University of Alabama at Birmingham and its School of Optometry and Department of Ophthalmology, which is part of the School of Medicine, to create the Center for Low Vision Rehabilitation, and it has just been a wonderful success. It offers a comprehensive approach for quality patient care, teaching, and research in the field of vision rehabilitation. And through the activities of the center, patients are provided with patients whose vision impairment is not correctable with glasses or contact lenses or other surgical or medical treatments are provided with assistance to help them maximize the vision they have remaining. And this is brought about by experts in ophthalmology, optometry, occupational therapy, and psychology. And it's a very good comprehensive approach which provides the best outcomes for the patients. Since we got involved, we've invested almost $2 million in this various aspects of this program, operating support, capital and equipment needs, recruitment of staff, and also very important research, scientific research in various aspects of low vision. And of course, the star of this program is Dr. DeCarlo. She holds degrees in optometry and public health from UAB. You can see on this slide she's done wonderful postdoc training. She's on national committees. She is actually a rock star in the low vision field, and I'm not just saying that because she's one of our favorite grantees, but her patients love her, and this program is one of the Eyesight Foundation's sort of star pet project programs. So without further ado, I'm going to turn it over to Dr. DeCarlo, and she can tell you much more about what her work is all about. Dawn?
Thank you very much. I'm very excited to be here, and I want to thank Tori for the opportunity to speak to your group and Patty. And I want to also acknowledge the eyesight. Sorry.
Back up one.
Yeah, I clicked on the wrong thing. Let me get this right. Okay, now I'm clicking right. Okay. I also want to, sincerely thank the Eyesight Foundation because what we do is really special, and it's able to be special because of their support. So the kind of care that we give can't happen in a 15-minute encounter. And without the support of a foundation like the Eyesight Foundation, I would have to limit the amount of time I can spend with a patient and wouldn't be able to meet all of their needs. So it's hugely important to us to have the support of a foundation like Eyesight, Foundation of Alabama. So to tell you a little bit about our center, that's our front door looking into our waiting room. We are officially sort of, I guess, owned by the School of Optometry and the School of Medicine, but we also have significant ties to the School of Health Professions and the School of Education. What we do here is we aim to maximize a person's visual function through the use of many different types of equipment, including lenses like the standard kind that you see in glasses, filters to attenuate the light, special lighting, training to help them use these devices, or just to simply use the vision they have better even without devices, so that we can maximize their quality of life, including their safety, and promote their independence. I know that in the field that you're in, you guys all hear the term all the time, aging in place. Well, it's harder for an adult with vision impairment to age in place if they're unable to remain independent. So in terms of who actually physically works in here, we have 3 optometrists, all with residency training in vision rehabilitation. Dr. Marcia Snow, Dr. Lynn Stevens, and myself. We also have 3 occupational therapists, although only one of them is full-time. And Mary Warren would be the most famous of them all because she is sort of the rock star of the OT world in terms of providing vision rehabilitative care, and is about to be appointed a co-director of the center, which we're thrilled about. But in addition to that, we also work with orientation and mobility specialists, who are people who teach people how to use the long white cane. Most older adults don't need that, but some do. And teachers of the visually impaired, who are the teachers who actually go into the school system and help children with vision impairment to function as maximally as possible while having their vision minimally impact their educational abilities. We have a rehabilitation psychologist who is in the Department of Ophthalmology that we can work with patients with who have adjustment issues. And we also work with rehabilitation teachers and vocational rehabilitation counselors who work for the state. So we work with people within UAB and also outside of the university, whatever that patient needs to maximally promote their independence and safety. So, we've already said that these are people who have a vision impairment that's not correctable with medicine or surgery or standard glasses or contacts. But, it's very hard. Like, if you're looking for an actual definition of low vision, everybody's going to disagree a little bit, because if you try to put a number on it, like, oh, if you're 20/40, you're low vision, if you're 20/60, you're low vision, nobody really agrees on a definition, and so it's kind of hard even to compare studies to each other because a lot of times they use different definitions. For me, it means that vision is not adequate for that person's needs. So it's a very person-oriented definition, and there are codes that doctors can use on their fee slips and things to denote this, but typically it just implies some reduction in visual acuity and or visual field that renders their vision not good enough for what they need or want to do. And legal blindness is a special subset of vision impairment where the federal government has decided that once you get to this certain point of visual acuity, it's going to have some negative impacts on you. It was actually in 1935 when the Social Security Administration created this definition. It was termed economic blindness. Actually, it was the AMA that created it for the Social Security Administration, but that's who sort of vets this definition. And it's visual acuity in the better eye, best corrected, less than or equal to 2200. And some of you might have been told by your eye doctor that without your glasses you're legally blind. That's actually a nonsensical thing to say, because legal blindness only pertains to with best correction. So you cannot be legally blind in any way, shape, or form unless it's both eyes and can't be fixed with glasses. And people who are legally blind do have a few special benefits that other people don't have, including some tax benefits and things like that, although most people would, in a heartbeat, trade that for perfect vision. In terms of the numbers, it's really hard to find numbers because we don't have a registry. So everything is sort of based on different population-based studies of eye disease and vision impairment, and then sort of applied to the latest available census data. This is an estimate from the Journal of the American Medical Association in 2006, where they estimated that there are about 14 million people in the United States, of which 11 million had visual impairment that could be corrected with glasses or contacts. And we actually had a significant problem in this state with children who had vision impairment that was correctable with glasses, and they just weren't getting what they needed, and we now have an organization that's helping to meet that need in young people. But there are at least 3 million that have vision impairment that are what we're talking about today, the people who can't be corrected with glasses or contacts. And depending on where you look at these estimates, the estimates of people who have true vision impairment can go as high as 19 million in this country. That's how inaccurate these estimates are. It depends on how you define it and what studies you're looking at. So it's a very nebulous thing. I can tell you that last year we saw over 650 new patients with vision impairment. So those were just new ones who had never been here before. So we don't, unfortunately, have any shortage of those patients in Alabama, and all states are kind of in a similar situation. As it pertains to your group, you can see by this graph that the prevalence of vision impairment is actually pretty low for people in younger age groups. But as you start to approach the old, those over 85, the prevalence is getting upwards above 15% for most racial and ethnic groups. If we look at just blindness, the prevalence of blindness, meaning legal blindness, is much lower, but whites and blacks have prevalence rates of over 6%. That's high if you think about 6 out of every 100 people over the age of 85, and I see lots of patients over 85. My average patient is 84, or the average patient of our clinic is 84. So it's definitely something that's on the rise. As the baby boomers age, we're going to have more and more people that need help, and as people live longer lives and we see more people making it to that 100-year mark, we're going to have higher numbers of people who need our help. So who can we help? What I always tell the doctors who refer to us, because we're essentially a tertiary clinic that receives most of their patients by referral from doctors, that we can help anybody that has a functional complaint about their vision. So it doesn't matter to me if that patient's 20/20, and I've had patients like that sitting in my chair saying, I realize I probably don't belong here, but I'm having problems with X, Y, Z. So if they're having problems with something and their retina surgeon or their glaucoma specialist doesn't know what to do about it, this is a great place to send them. But the most common things that we hear about is reading. That's by far and away the number one reason. In a recent study we did of 225 patients with macular degeneration, 84% had reading as their main goal for why they came. But they also have problems with writing checks or doing their own financial management. A lot of people are very private, don't want their kids or other people helping with that. They have problems with driving at night, preparing meals, getting around, taking care of their medicines. I've had people bring in a bag full of medicines, dump them on the table in front of me and say, I don't know what to do with this. I can't even see the labels. So there are some people who are, need more help than others, and some just are having a little bit of trouble with their, reading their newspaper that they really enjoy. And we know that quality of life, this is from a study that we did here at UAB and published in 2004 looking at quality of life. And we know that the quality of life, and this is measured using an instrument called the National Eye Institute Vision Function Questionnaire, we know that quality of life is affected in AMD, which is age-related macular degeneration. I'll talk about that again in a little bit. That's the number one cause of vision impairment in older adults. We know that it's dramatically affected because 100 on these scales is representative of perfect quality of life and health-related quality of life. And you can see that our patients in general, their scores are mostly below the 50 percentile for things related to their vision, like their general vision, their near vision. And the gray bars represent patients who have both eyes better than 2200, which wasn't very many in our study. But their quality of life is better than people who only have one eye better than 2200, and those are better than people with neither eye better than 2200. So some people kind of feel like, well, as long as they have one good eye, they're fine. And this data sort of shows that one good eye is not good enough. And I love this picture. These pictures were published in Archives of Ophthalmology in 2001, and I've used them a billion times in lectures. This is an artist who, with the right picture of the peaches, he painted with his left eye covered, his poorer eye covered. The middle picture he painted with his good eye covered. And then the picture on the right, he painted with both eyes open. So actually, for that particular patient, that poorer seeing eye actually was degrading their perception of their vision and negatively impacting how they function. So that doesn't mean we should occlude their eyes. It means we need to do some other things to help them work this out, because people generally do need their side vision of their fellow eye, even if it's not great. So I want to go into now just a few patient stories. So I think all my patients are perfect. So this is the first perfect patient. This gentleman is a 54-year-old white male who presented having actually been recently released from prison for some sort of white-collar crime that I didn't really go into with him. But his goal was to go rejoin the church choir, and he wanted to be able to read the hymnal to sing in it. What he found was that he couldn't read the hymnal at church, and so he couldn't do that activity, and that was very part of him reintegrating back into his community. His acuity measured 20/50 in his right eye and 20/60 in his left eye, which means, to give you an idea of those numbers, if you're 20/50, then compared to somebody with perfect vision could see the same thing from 50 feet away that you would need to be 20 feet from. So you have to be about 2.5 times closer than somebody with perfect vision if you have 20/50 acuity. And at near, he could only see letters that were what we call 2M in size. So a 1M letter is the size of newspaper. So he needed something to be twice as large as newspaper to see it. And we gave him extra light, which is a strategy we always try first. It didn't really change anything. So what we ended up prescribing were some really strong reading glasses. And you can see from the picture of these, we do have some prettier frames than the one I took a picture of. But you can see that they're very, very thick in the middle. And these glasses have strong prisms in them to enable you to hold something closer yet still have both your eyes focus on it. And we find these very effective for people who need hands-free viewing, who don't mind holding things a little bit closer, and who don't need a lot of light. He was absolutely thrilled and went on to rejoin the church choir and is doing quite well. He also is, his diabetic retinopathy is improving now that he's under more regular care. Not that he wasn't when he was in prison, but I think that I don't think people realized what was going on with his eyes at the time. But importantly for people with diabetes is if you have diabetes and you have a vision impairment related to it, it's going to impact all kinds of things. Number one, if you need to be measuring your blood sugar or measuring your insulin and you can't see well enough to do it accurately, that's going to impact your overall diabetes control. If you can't see well enough to read the labels on the foods that you're choosing to eat, that's going to affect your diabetes control. So it's really important that the devices that we prescribe either enable them to be totally independent just by virtue of using the device, or if their vision loss is more severe, that the device is not alone going to take care of those needs, then we work with occupational therapy. I'm going to talk about that a little bit later, to show them new ways to do old things so that they can manage these things safely, accurately, and independently. This Prodigy Autocode is one of the devices that we use because it's a talking glucometer, so it actually has very big numbers, but it also will talk to the patient so that they can keep a good eye on their blood glucose levels. Here's another patient, and she's 71. She wants to sew and read menus, which are two common problems. She had dry macular degeneration in the right eye and wet macular degeneration in the left eye. And the picture you see up there is actually the picture of the inside of her eye. The circular thing with all the red lines coming out of it is the optic nerve. All the red lines are blood vessels. The lighter colored ones are arteries. The darker colored ones are veins. And that mottled lightish area sort of almost in the middle of your screen are irregularities underlying the retina in what we call the retinal pigment epithelium that are disturbing her vision. So this is a intermediate stage of AMD, although she has advanced AMD in the other eye. And her acuity with this eye is actually still pretty good. She's seeing 20/40, but she has severe functional complaints. And a lot of that is usually related to the fact that you can see something on an eye chart where, an eye chart is very black letters on a very white background. So that's sort of the perfect viewing scenario. But if you have macular degeneration, you're not looking at eye charts, you're looking at real-world things, and real-world things are generally not the perfect viewing scenario. We have all kinds of colors and shades of gray. So on real-world objects, she does much more poorly. And her contrast sensitivity, which is a measure of how well you see things when they're similar to their background, was actually in the moderately severely reduced range. So that was a lot of what was affecting her. For sewing, we ask our patients to bring with them devices that they use, things that they're having difficulty doing. And so this lady actually brought her sewing machine and a skirt that she was trying to make with her to the exam from 2.5 hours away. And we ended up using a magnifying lamp where the lamp and the magnifier were separate. So she could direct the light right on the footplate area, and then we had the magnifier in front. And that worked quite well for her sewing. And then there's a picture of a little magnifier next to it where that magnifier has an intense light in it. So if she was out in places like restaurants where lighting is typically not great, she had a built-in light source and a little bit of magnification. Another newer thing that's working well for some of these patients who just need a little bit of help are these Illuminated. You might have seen the commercials on television. Foster Grant makes these, and they have built-in LED lights on the sides of the glasses that actually give quite a good light source to the reading material, and some patients can do quite well with them. I didn't show them to her because they weren't available yet, but if she were to show up again today with those same symptoms, I would definitely demonstrate these. So they're a pretty nifty little thing. Here's another patient and something that we might do to help them. So this is an 88-year-old white female who wants to read her Bible in Braille, and being down here in the Bible Belt, that's a very, very common goal. She has wet macular degeneration, which means that there are new blood vessels growing underneath the retina, the seeing layer of the eye. It's the layer of the eye that captures light, turns it into electrical signals that are then transmitted through nerves back to the brain so the brain can interpret it as vision. In wet macular degeneration, those new blood vessels are never a good thing. They tend to be very fragile, and they break and bleed, and then that causes scar tissue, which cannot be removed by any means. So this patient is fortunate enough, the right eye has been seeing poorly for a number of years. The left eye just started developing those new changes, and she's been receiving a new medication that's been used since about the late middle 2000s for treating macular degeneration. It's an anti-vascular endothelial growth factor that helps stop the growth of these new blood vessels and helps maintain vision. Unfortunately for this patient, even though that was the case, the vision at near was rather poor, and she needs things to be about 4 times the size of newsprint to be able to see it. But being an older adult, she also had some complications. First, she had 3 errors on the short portable, which is a very short mental status questionnaire. 3 errors, while that would be characterized as mild cognitive impairment, in my experience, that's actually a lot for this test. And so I was a little bit worried about trying to teach her new things for fear that her short-term memory wasn't going to really let her do that very well. She also had Parkinson's, so she had a bit of a hand tremor, and I was worried about anything that I asked her to hold on to might not be, she might have a difficult time. So what we ended up doing with her was using a stand magnifier, and you can see from the top picture that it's much larger than any little magnifier that you're used to, in that the stand holds it the right distance from the page. And you can see looking into the picture on the bottom part that the illumination really brings out that print. So it makes it bigger, plus it lights it up, which really helps with any decreased contrast that the patient has. The danger of these things is patients always want to know, well, what X is that? Well, I think I need a this X or that X. X is very relative, and the actual amount of power that you get from one 4X magnifier is not necessarily the same as you're going to get from another 4X magnifier. So we, as eye doctors, speak in diopters, but that's just kind of a word of caution that if it were that simple as just needing an X, you probably wouldn't need me. So here's another patient, and this one, again, has good vision in the right eye, poor vision in the left eye, and their reading speeds, they can read print smaller than newsprint, which is what that MPS is. That's the minimum print size they can read, and the critical print size, however, is bigger than newsprint. That's the smallest print size that they can read at their maximum reading rate. And one of the reasons in this patient that that's a problem is that their contrast sensitivity, remember the ability to see things that are similar to their backgrounds, is so reduced. So that's a severe reduction. And if we look at the inside of their eye, and this is a picture, a black and white picture from a test that we call microperimetry. So all of those little triangles are places where we flashed a spot of light onto their retina, and they could not see it, they did not respond to it. The little red circles are places where we flashed a small spot of light, and they were able to see it. So you can see there's a little pale purple cross in there. It actually is much more obvious to see on the machine than it is in this picture. But there's just a small little area between those areas of atrophy, which are hallmarks of dry macular degeneration, where this person's seeing. So it's almost like they're kind of looking through a little straw because they only have a tiny area that sees surrounded by larger areas that don't see. So when you have that situation, we really can't do very much in terms of magnification, because we make it bigger, it's going to magnify it into the areas of retina that don't see. So some of the things that worked very well for this patient, who happened to be a university physician, retired but was trying to finish up his research and things, he found a backlit keyboard. So he found that on his own, and that actually worked very well for him to help with his keyboarding. And I often recommend little tiny LED flashlights for these patients because it provides an intense light source. And by providing intense light to patients like that, oftentimes that's enough. And all lights are not created equal. This one is kind of an advertisement for OT light, but it doesn't need to be an OT light. There are other natural daylight style bulbs, and you can see that the standard light on the right is kind of yellowed out, whereas on the left, I'm very directionally challenged because as an eye doctor I'm always saying look to the right, which is my left, and so my husband won't take directions from me because I don't know my difference anymore. The picture on the left is a standard light. The picture on the right is with a natural daylight style bulb, which gives a very white, bright light. And when I have patients compare that, 99 out of 100 is going to prefer that very white light. And those are available in many, many places commercially. So in terms of what we did there, besides him finding the keyboards and the lighting, basically we didn't have a lot of optical options of what we could do for a patient like this. One of the things that we could do is try to train them to use an area of retina outside of those scars. So you can see his picture in 2008, and this is the same patient in 2006. The same patient is in 2008. So you can see how much that lesion expanded over that year period, and his acuity decreased. So we could train him to use retina outside of those scars, like this patient is successfully doing. You can see that there's a large scar in the middle, and there's the cross is outside of that. But we find that doesn't work very well for patients who still have any area that they can see within their central vision. So the main thing we can do for patients like this is utilize the services of occupational therapy. So they can help with all kinds of areas of everyday life. So having that big scotoma, even though his vision was good in the center, it was almost like having donut vision. You can see through the hole in the donut, then you have a big missing area, and then outside of that it's normal. So they have problems with things like dropping a number or a letter off of a word or a longer number. They lose things. They'll put something down on the counter. They can't find it. They have to keep looking around, and then all of a sudden it sort of pops into their vision out of nowhere. And it can be very frustrating, but occupational therapy through training can really help them compensate for this. Here's another case. I think this is my last case, and I'm going to talk about a couple other different things. Is a person who actually has a macular hole. So that little red spot right in the middle of the retina is the macula. Typically, you wouldn't see that almost bullseye appearance, but a piece of the macula has been torn, and now a hole is developed there. And surgically, that's very often closed now, but sometimes you get resolution of the vision after you close the hole, and sometimes they can close the hole, and anatomically it looks great, but the patient still doesn't function well. But this is in my clinic, they're a little bit younger than average at 83. She read a novel a week and the newspaper every day. She lives alone. She doesn't want her kids to know anything about her finances because that's personal. She doesn't think they need to know. And she has never seen well with her other eye. And then she starts telling me she sees people walking up her driveway, but there are no people there. She realizes that they're not there. It's actually quite common in older adults to have complex visual hallucinations if they have vision impairment. And it's been reported as high as 40% of older adults with severe vision loss. But the main difference between this and the hallucinations of somebody who has true psychiatric problems is that people with vision loss always know. They tell me, I know they're not there, but I'm bothered that I see them. Or they say nothing at all because they don't want their kids to think they've gone nuts and then put them in a nursing home. So the best thing that somebody can do for a patient like this is just reassure them that it's a very common event. Sometimes this goes on for a year or more. Sometimes it goes away rather shortly. So it's variable, but it is in the spectrum of normal in the state of vision impairment. Depression is another problem, and there are several depression screeners out there that we use. The depression score on this patient was 32. So that is highly suggestive of depression. And in earlier studies, the prevalence of depression in advanced macular degeneration was found to be as high as 30 to 35%. More recent studies have much lower numbers in the teens. So it is probably a little bit higher than in the general population, but maybe not as high as we once thought it was, and perhaps that has to do with the newer treatments. I see that patients are seeing much better than they used to. I've been practicing for 20 years, and the patients that I see in the last 5 see better than the patients I saw before that. So perhaps it's just that with the better treatments out there, there's more hope, more people are keeping vision longer, and that may be affecting it. But there have been some studies looking at how we treat this. There have been problem-solving treatments, so teaching people how to sort of self-manage their depression. There's been a small study looking at the selective serotonin reuptake inhibitors, that's like Prozac and Zoloft, and that seemed to be positive as well. Dr. Robner is currently looking at, does low vision rehabilitation affect depression status? And here at UAB, we also have a study that Dr. Laura Drew has been doing on the same things, but there aren't any publications out about that just yet. So for this patient, what we opted for was electronic magnification, because as you can see in the picture in the upper left-hand corner, we can take something very small. So she's magnifying a medication bottle there and make the letters quite large on the screen. We can put newspapers under here, and patients can read much faster and for longer periods of time, generally with these devices. She was thrilled that she was going to be able to read her Bible and her newspapers and her novels again, and this made all the difference. So a very sad, depressed-looking woman came in, and a very happy, practically bouncing off the walls with excitement woman left. We can also help people who want to use their computer. So if they're looking to read emails from their grandchildren, they can't see it, there are several different things we can do. The most complex is a software that people with who are blind use, meaning blind as in not really being able to read print, and that's called JAWS, and there are other versions of that. But most of our older adults don't need that. They need something less. Sometimes it's just a matter of getting a bigger monitor, but ZoomText is a screen magnifier that works with virtually any kind of computer program. And Microsoft now has computer mice that have built-in magnifiers where you can just with a click on that little red button on the side of that mouse, it'll enlarge things up to 5 times. So there are lots of simple things that can be done, and we usually implement those strategies with occupational therapy. I put a guide dog slide in here just to let you know that most older adults do not utilize guide dogs. They can. There's nothing that says an older adult can't use a guide dog, but in general, they just don't need them to maintain their independence, because most older adults have causes of vision impairment that spare their peripheral vision. Even the patients with glaucoma, where the side vision might be impacted, generally don't go on to use guide dogs. Their travel is not as rigorous as a working age adult. But it is important that to have a guide dog, you must be legally blind. You must already be very good at using cane skills. So you might have seen people using the long white cane with the red tip. You have to be very skilled in the use of that. And you have to be able to care for a dog. The picture of the guide dog on the left is actually a guide dog that helped save that man's life and led him out of the Twin Towers on 9/11. So that guide dog made an impact in his life on an everyday basis, but in a very profound way on that day. A lot of our older adults want to drive, and we did a study here looking at driving and vision impairment back in 2003, and found that most of our macular degeneration patients had given up driving. Those patients did not see as well as the patients that we're seeing today, however. In Alabama and about 39 other states, you can drive with a special type of telescope called a Bioptic, and this young lady, who is obviously not an older adult, is wearing a special telescope on the top part of her glasses, and we call that a Bioptic telescope. So this could help somebody if they believe that their vision is adequate for driving, but they're having some difficulties that being able to see things a little bit sooner could help them with, and they're not able to be licensed because of their acuity otherwise. So the idea behind a bioptic is just that you look through the regular part of the glasses most of the time, as you can see from the picture on the left, and then if you need more detail about something, is that a trash can on the side of the road or a child that might run out? You just tip your head down, which brings the telescope into your line of sight, and it gives you more information. Or is that traffic light up there red or green? And we always take our patients out on the street using a monocular telescope, or using the telescopes that we're considering to see how they feel it will benefit them in an on-street situation. And we might loan them a monocular telescope to let them practice, especially for older adults, because this is not typically their first line of choice in terms of driving. The type of telescope is very important. This is the view actually right outside of Tori's office, so I always go right out in front of her office. I don't know how often she sees me out there, but the yellow circle is surrounding a traffic light about a half a block away. And then you can see on the right-hand side of the screen, that's a 4X expanded field telescope, and below that is a 4X Galilean telescope. So you can imagine that although these two are the same power and they make the traffic light about the same size, it's going to be a lot easier to use the one with the larger field of view. So we always want people to have the opportunity to see the devices that we're working with. There are a lot of articles sort of targeting older adults for driving with these telescopes in like Reader's Digest and some of the senior living magazines. It requires a lot of training. It's a little bit, many of those things are presented to older adults as here's a magic fix. And what we try to explain here that driving with a telescope is a process. It's not a, here, put this in your glasses and you're good to go. So we do have the occupational therapist work to make sure they're able to quickly get in and out of the telescope. And then we have them work with a driving rehabilitation specialist to make sure that they're able to incorporate that into their driving to make sure that the telescope is enhancing their safety, not minimizing their safety. If you're distracted by a telescope, you can't necessarily be a safe driver. So that's pretty much what we do for the older adults that present to our clinic. We do take care of people from birth to over 100, but the vast majority of people who need vision rehabilitation services are older adults. And if you have somebody in your area or you know somebody who needs vision rehabilitation, there are lots of resources out there, and I can certainly point you to directions in your states if you need any help with that. It's something that unfortunately has not entirely made its way into the medical model. So vision rehabilitation sort of grew up in the educational model where rehabilitation teachers help the older adults, and special teachers in the classrooms help the younger adults. And eye doctors, unlike orthopedic surgeons, really have never fully gotten into the habit of, if we can't fix you medically or surgically, then rehabilitation is the obvious next step. In some places where there's easy access to care, like here at UAB, thanks to the Eyesight Foundation, that is an obvious next step for many patients, and many patients get that help. But in places where the services are not as obvious, a lot of times that patient doesn't get put into this next step. So nobody would ever expect to have an ACL repaired and not get physical therapy. But it's quite often that a patient has a vision problem and doesn't get that help. So I just want to send the message that help is out there, it is available. Sometimes you just need a little bit of help finding it, and it's a very important part of the whole eye care process. So with that, I just want to say thank you for having me, and I'm happy to answer any questions. And Tori is standing right here with me, so either one of us can answer any questions that y'all might have, and thank you again.
Excuse me. Thank you, Dawn. Not seeing any hands raised or anything in chat, let me start with a question about how do people pay for these things?
That's a great question. So most of the time, the medical part of their eye exam is covered, and for most people, they're depending on their plan, but most insurance plans will pay for occupational therapy.
Okay.
In a few states, some of the devices are covered under Medicaid programs, but Medicare never covers anything with a lens. That's the only time that Medicare is going to provide anything with a lens is one time in your life after cataract surgery.
Oh.
Otherwise, these things are specifically prohibited in the Medicare statutes. So in our state, we have two main possible ways that we pay for devices for people who can't afford them, like three. So one is if they're younger, vocational rehab will often help them. Or if they happen to be a working older adult, then vocational rehab will often help provide these devices, especially if they enable them to stay at work. If they're low income, then we have a grant through a local foundation that can help us. We have Songs for Sight was a fundraiser that Eyesight Foundation was intimately involved with that provides also devices to patients of our clinic, or the most common way is that patients pay cash for the devices. Now the magnifiers can be as inexpensive as $5, but the average ones are between $50 and $75. The telescopes are, when they're spectacle mounted, are typically between about $700 and $2,000 here in our clinic, which is a lot less than in a lot of places. And the electronic equipment and the software can actually be very pricey. The software, can typically more than 100, and some versions are in the 500 range. The video magnifiers typically between $1,800 and $3,000. So some of them can be quite pricey, and that is difficult for some patients.
Having run a library, I know how expensive JAWS is.
Yes.
And Patty, this is Tari. I'd like to add something just so the group understands. When the Eyesight Foundation initially took this on as a specially targeted program of support, we sort of had in our mind that over time it would become self-supporting. But one of the things that's a challenge that has made that difficult is the nature of the work that Dr. DeCarlo has just described to you. Don, I believe you've told me in the past that if you have 8 patients in one day, you're pretty slammed. It's very tedious. You're in particular with the elderly population, you're working with people who might have other issues going on, healthcare issues, cognitive issues, the depression, fear, and which translates into one of the reasons her patients love her so much is because she's so good and patient with her patients, and most of the time she's able to help them in some way. But Monday, I was talking to the chairman of the Department of Ophthalmology and just asked him what he had going on that day because we were trying to set up a meeting, and he said he was seeing 85 patients. He is a glaucoma specialist. So you see the contrast. So, he's getting reimbursed for 85 patients. She's getting reimbursed for 8.
Mm-hmm.
Yet it's a life-changing event for the people who receive care here.
Okay. Who do we have left? Let's see. I think Katie left. Okay. Shirley, did you have any questions?
I wonder if she's having to answer the phone or something. She's the only.
Oh, this is Shirley. I've been on mute.
Oh,
wonderful,
okay.
Wonderful presentation. I wonder, and you may have touched on this and I missed it, but I know we do this here in Birmingham for the residents of Alabama, but Dr. DeCarlo, how prevalent is this? Do most states have an opportunity like the Center for Low Vision Rehab that we are fortunate enough to have here, or is this a rarity?
I think it's relatively uncommon. There are some places, some of the places that have more dense concentrations of older adults have probably more access to this type of care. And, in Florida, there are several lighthouses for the blind, and in New York. And so in many of the bigger cities, there are services like this. There's certainly, at Emory, they have a low vision clinic over in Atlanta, and there's a Center for the Visually Impaired there. But, the services are less at many places, and in a lot of places, in a lot of universities, they will have an optometrist in the Department of Ophthalmology who provides low vision services, but a lot of times they also do the contact lens care and other things. Mm-hmm. So to have the access to an occupational therapist and the School of Education and the School of Health Professions and Psychology and Ophthalmology and all of this housed in one place, we actually are lucky to be a pretty special place.
Well, we feel very fortunate to have you in the center here in Birmingham.
Thank you. I feel very happy to be here.
Well, we hope with this recording we're going to get out the word about your work to a wider audience, and we appreciate you putting this together today. Do Tori or Dr. DeCarlo, do you either have any closing remarks to make?
I would, if anybody wants to know more, I would encourage them to contact us at the Eyesight Foundation. The SECF members should be able to find our website, which is www.eyesightfoundation.org. Dawn, what is yours?
My email is just my first initial, my last name, so ddecarlo@uab.edu.
Okay.
And Patty, this is Shirley again. I will also say that I think we have some of the same issues you just mentioned, is that, awareness. There are a lot of people here in our state, in our area, who simply aren't aware that this opportunity exists here. So, there are people who have low vision who could benefit from this, and just we always struggle with how to get the word out that it's here.
Yeah, to fill up Dawn's hours even more. 8 people every day. But we thank you both for making the presentation, and we'll let you know when it is posted to YouTube, so you can check it out. You can link to it from your own website and that sort of thing. You're welcome to do that. And next month we're having a presentation on workforce issues by the Encore Fellowships Network out of California. So thank you all.
Thank you, Patty, for organizing it. We appreciate it.
Thanks, Pat.
Thank you. Please stand by.